Thank you so much, everybody. I'm really excited that everybody's here. If you didn't notice, Dr. Appleby's ribbon runs with scissors, and somebody left scissors on the stage, so watch out. And thank you for all of you tuning in at home as well. So as she mentioned, my talk today is about taking care of your body, the uncommon topics in PD. By uncommon, I don't mean that these are unusual symptoms, rare symptoms, or weird things, but rather topics that exist but often are not talked about. But whether you're looking at the important wellness concepts that Dr. Lefevre just talked about, or the very specific topics that I'm going to talk about, that I'm going to discuss with you, the question is, how can you be successful in optimizing your health? Next slide. And the bottom line is that you can't do this alone. You start by building your team, whether you are newly diagnosed and you start to add in team members, or whether you've had Parkinson's for a while and as time goes on, you realize that you need to add more team members. And this is the case for all of us, right? Whether we have Parkinson's, we don't have Parkinson's, we all have our team that helps take care of us. And unfortunately, I don't have control over my slides, so there's going to be a lot of little things popping up right now that kind of represent all the different specialties that might be a part of your care and your team. So for these three, these are just three care team members, the dermatologist, a vision specialist, and a primary care provider, that the topics I talk about go in hand with these specific providers. Before I start talking about the different topics, though, a few notes. So number one, just because I'm talking about it does not mean you are experiencing it. I don't want you looking at the topics and think, oh great, just one more thing I have to worry about with Parkinson's disease. That is not the point. In fact, the point is the opposite. Because whereas the afternoon is talking to you about the updates in research, the updates in medical treatments, surgical treatments, this morning is about taking care of your body. So we had a lot of great ideas from Dr. Lefevre. And then with me, again, I'm talking about some very specific topics that we don't talk about a lot. And it's just to make you aware that these may happen, identify those potential concerns before they become a problem, and then seek out your team members to get the care that you need. Number two, just because you have Parkinson's disease does not mean that everything that happens to you is because of your Parkinson's disease. That's how big things get missed. And it makes me really sad when somebody comes to me and they're saying, oh, well, they just said it's my Parkinson's disease. I'm like, there's no way that's your Parkinson's disease. So if you have a concern, again, just because you have Parkinson's disease doesn't mean it's always Parkinson's disease. And number three, for each of the topics I mentioned, I'm going to speak briefly about them for the sake of time. I'm not going to get into the science of any of it, not how my brain works, but instead I'm going to focus on what it is, again, briefly, what to look for, and who on your team you can go to for help. So the first thing I'm going to talk about, and bear with me, the slides are up there, so I can't see them completely good, so bear with me if I'm off a little. But the first thing I'm going to talk about is eye health. So specifically, I'm going to talk about double vision, dry eyes, and depth perception. Next slide, please. So double vision occurs in about 1/3 of people with Parkinson's, and I would imagine if you have it, it's very frustrating to read or to perform other types of tasks. So double vision is exactly what it says. You're seeing double of something, you're seeing two of something. There can be many causes that are not related to Parkinson's disease, so problems in the front of the eye, such as cataracts, or it can be related to Parkinson's disease. So when someone has two healthy eyes, but they're pointing in slightly different directions, and then when they try to pull them together, they start to see double. So how do you know if it's a Parkinson's disease related or not? Well, really, it's not your job to figure that out. It's really the vision specialist who you have on your team. But basically, in general, if you have double vision, you cover an eye, and the double vision is still there, then it should not be related to Parkinson's disease. If it goes away, then it probably would be related to Parkinson's disease. And that's why sometimes they will treat the double vision with an eye patch. You might see somebody walking around, and that helps treat their double vision. Sometimes they'll use prisms. And if you've had this problem, there's some people who get the prisms, they get an eye patch, and like, oh my gosh, this made all the difference in the world. Sometimes it doesn't make a difference at all. And it's okay to get a second opinion. Vision is our dominant sense. And so if you are having problems with it and you haven't got the help you need, before you give up, seek out another opinion. A problem that might cause double vision is dry eyes, and that next slide, and that is something that people with Parkinson's often experience. So our eyes get lubricated by blinking. People with Parkinson's disease tend to blink less. Now, if you're more active, you're exercising, you're doing other things, then you probably are blinking a little bit more. But in general, people with Parkinson's are blinking less. And so when you are blinking less, then that can cause the dry eye. The dry eye can cause some scarring of the cornea, which can result in some permanent vision changes. Next slide. But of course, we don't want that to happen. So how do you know? Because sometimes people don't realize it. So what are the symptoms of dry eye? Sensitivity to light, might see a glare, there might be some pain. I know this sounds funny because we're talking about dry eye, but then I'm going to tell you tearing of the eye is one of the symptoms, and then people can feel irritated. Do the Parkinson's medications help? They don't. And in fact, there are some Parkinson's medications that can actually make the dry eye worse, specifically amantadine and artane. But most of the regular Parkinson's disease meds will not help it or probably will not cause it. How is it treated? So you can use eye drops, just simple over-the-counter, preservative-free. They have to be preservative-free eye drops. You can use them 4 or 6 times a day. If you forget to use them and you've been told dry eye is a problem, maybe use the eye drops when you're taking your other medication. You want to avoid eye drops that say reduce the redness. Those are not good for you. If those don't work, you can get prescription eye drops, and then if more severe, there are procedures that can actually be done to help the dry eye as well. Next slide, please. So the last topic in eye health is depth perception. So this can happen when there's a loss of vision, there's double vision, and or the brain and the eyes are having trouble making that connection, and that can happen in Parkinson's disease. So the eyes see something in 2D, the brain needs to convert it to a 3D image so you kind of can know where things are and where you are in space. So when this happens, what are the kinds of things that you might notice? I'm not asking you to raise your hand, but just thinking to yourself, how many of you who are driving have trouble parking the car? Because you're having trouble with that spatial awareness, that depth perception. How many misjudge a step? You think it's lower than you think it is, it's higher than you think it is, you think you're at the end of the steps, or maybe the same with a curb. It doesn't look as short or as tall as you think. Or you go to grab something, you go to reach for that glass and you knock it over because the depth perception is off. Next slide, please. So how are some ways we can treat this? Now, if there is another cause that is causing the depth perception that's not just related to Parkinson's disease, then treating that other cause, and again, that's where that vision specialist comes in and they can help you figure that out. If not, go back, please. If not, there are some things that can be done. So one thing is, I think an occupational therapist can probably help. They're not going to take away the depth perception problems. They're not going to restore your vision. But an occupational therapist's job is to take to them the problems you're having trouble with, and they're problem solvers. So if you have found certain things that are trouble for you because of this, then they can help come up with some problem solving ways to do it. So some things that might help, if you have some steps outside that you're missing, you can put on the safety color strips. With the driving and the parking depth perception issues, it is said to be that if the car, like the windshield or the lights are dirty, it causes a glare, and that can make the depth perception issues worse. So you want to keep a clean car. And then there can also be just, having brighter light in there and not having a dark room that's casting shadows and stuff that might cause other issues. So next slide, please. So the bottom line with eye health is you need to make sure you have a vision specialist on board. And I put vision specialist because there's optometrists, there's ophthalmologists, and then there's neuro-ophthalmologists. But you need to have one on your team. You need to get regular eye exams. And if you're having concerns, make sure that you bring it to their attention and you get the help that you need. Next slide, please. So the next topic I'm going to talk about is skin health. And specifically for these ones, I'm going to talk about excessive sweating, seborrheic dermatitis, and then melanoma. So for excessive sweating, this is something that can be experienced by a lot of people with Parkinson's. So putting Parkinson's aside, what are some general causes? So people going through menopause or postmenopausal, cancer can cause excessive sweating, thyroid disease, sleep apnea. The causes are numerous. When it comes down to Parkinson's disease, what are typically, and there could be more, but what are typically the causes of excessive sweating? So one is sometimes people, if you are familiar with your meds kick in and you feel like good, and then your meds start to wear off and you're in an off state. Some people start to have excessive sweating when they're in that off state. And then another cause that can be related to the Parkinson's disease is people with Parkinson's can experience what's called autonomic dysfunction. So that part of our nervous system that we don't think about. Our heart, our lungs, our temperature regulation. And so that can be compromised. And so people with Parkinson's can just they can be cold, they can be hot, they can have one arm cold, one arm hot, and they can have excessive sweating. So where does this excessive sweating occur? So typically the head, neck, and trunk are the main areas, but of course it can occur in other areas as well. Next slide, please. What are the treatments for it? If other causes have been ruled out, so your thyroid's okay, you've been treated for sleep apnea, then if it does seem to be related to your off time, then hopefully some adjustment of your medication. We have all kinds of medications out at the exhibit halls that they can help with off time. So adjusting medications might be able to help, but there's prescription medications that can help. There's prescription antiperspirants that can help, prescription creams. People can get Botox injections. You know, they always say if you use one drug for everything under the sun, it's probably too good to be true, but I feel like that way with Botox. We're constantly saying, well, Botox can treat that. Botox can treat this. And then for people who all those things aren't working, there are some actual procedures that the dermatologist can perform to help with that. Next slide, please. So the next one we're going to talk about is seborrheic dermatitis. And what is this? So some of you may experience this because it occurs in approximately 20 to 60% of people with Parkinson's compared to about 5% of the people who do not have Parkinson's. So this is red, patchy, itchy, greasy scales occurring in different parts of the body, which I'll show you some pictures in a second. It can occur intermittently, but it can have flare-ups. Next, please. And those flare-ups can be stress. It can be using oily creams. And if somebody's really cold, that can cause a flare-up as well. Next slide, please. So you can see some pictures, and I'm going to step over so I can make sure I'm matching the slides. So some of the common areas, so it can be like under the eyes, around the nose, the eyebrow area. It can be in the scalp area. People also often have it on their chest, and it can occur like in your legs and around your belly button, other areas, but these are going to be the most common in Parkinson's disease. And then how do we treat it? So there can be some over-the-counter creams and shampoos. There can also be prescription ones, so there can be antifungal cream like ketoconazole. They'll use steroid creams like Desinide, and then the calcineurin and inhibitors as well. So there are different things that can be used to treat it. Next slide, please. So I'm going to take a few more minutes to talk about the last topic in skin health, and this is melanoma. And this, of course, a lot of the things that I'm talking about today are inconvenient. They might cause some, you to have some problems on a day-to-day functioning, but this is the one that's dangerous. So some studies have shown that there's a 2 to 3 times risk increase in people with Parkinson's of having melanoma. Some studies have shown like a 4-time risk of having it. Some studies have shown that you're at higher risk for melanoma before you're ever diagnosed. Other studies have shown that you're not at higher risk for melanoma until you're diagnosed. But the bottom line is it doesn't really matter because we do know that there is a connection, and more studies are showing this. And so you need to be aware so you know what you can do about it. Why does it happen? Again, lots of theories, so we're not going to talk about the science. Again, it's just important to know that it can happen. Does your medication cause it? And this is a big question. When I've talked to some people in the office and we talk about this, your medication does not cause it. But the reason people ask this question is if you actually read your medication inserts, every single one is going to have a melanoma warning. But your medication does not cause it. But that warning is still there. And I kind of like it only because it's a reminder to do what you need to do in regards to like skin. Next slide, please. So what are some of the other risk factors besides Parkinson's disease? So light hair, red hair, light eyes, a lot of sunburning actually increases your risk by 5 times. I don't know about you, but when I was a kid, we didn't use sunscreen. We laid out with oil on us. I don't think my parents owned sunscreen, whereas I don't think my daughter's ever had a sunburn because but the risk is there. If you are a person who has had any type of skin cancer before, if you have had a family member with skin cancer before, or you have a lot of moles, those are also other risk factors. Next slide, please. So what does it look like? How do you know if you have it? Again, not your job to diagnose melanoma, but I'm just going to kind of tell you about a few things to look for, but you really should be getting regular skin checks. So with melanoma, on the top, there's a picture of the skin. On the bottom, I wanted to include a picture of melanoma in the eye. This is a picture of the back of the eye. Melanoma does occur in the eye, and a lot of people don't realize that. I will be absolutely 100% honest. I'm not sure if there is the same risk of eye melanoma as there is skin melanoma. I've tried to look at it several times. I've never been able to find it other than the fact that one of the articles talks all about skin melanoma and Parkinson's, but they have a picture of the eye melanoma. So maybe, but regardless, it can, so that's where your sunglasses come in. So they talk about the A, B, C, D, E's of melanoma. A, so melanoma is asymmetric. It's not perfectly round like a lot of the other moles may be. B, the borders are typically uneven and they're typically scalloped, whereas for non-melanoma, they tend to be more even. C stands for color. When there's multiple colors in a skin lesion and a mole, doesn't mean it's melanoma, but that is a sign that it may be. D is for diameter. If the diameter of the mole or the area is bigger than a pencil eraser, then that is very concerning. D can also stand for the fact that there's dark. And then in one of the articles I was reading, I really liked it. They talked about the ugly duckling. So I kind of think of D for duckling. And what they meant by that is if you're somebody who has a lot of moles, they all look the same, but this one over here looks different, that's your ugly duckling. And that's the one to be concerned about and watch very closely. You should watch them all closely, but that one specific. It may be lighter than the rest, it may be darker than the rest, but that is your ugly duckling. And then E is for evolving. They change over time. Next slide. So what can you do? Be educated. That's why you're here, to learn about different things. Educate others. A lot of people, don't know about this. Monitor the risks that you can control. You can't control if you have blonde hair, blue eyes. You can't control if you're fair-skinned, but you can control wearing sunscreen if you're going to be out in the sun, and I want you out in the sun. We're going to talk about vitamin D in a second. We want you out in the sun, but for limited times and using sunscreen. And then again, because of that melanoma in the eye, you want to wear sunglasses. Next slide. So the bottom line here is that you need to have a dermatologist on board. There's, I named a couple of the skin conditions. There's others, but, getting regular skin checks is really important. And then I threw the vision specialist back down there because that's where they detect the melanoma. They might tell you, you know what, you have a freckle in your eye that we're going to keep an eye on. And that's what they're referring to, is they want to keep an eye on that freckle, just like the freckles, moles on our skin, to make sure that doesn't turn into melanoma. Next slide, please. So next I'm going to talk about bone health, and we're really just going to focus on osteoporosis. So our bone is constantly being broken down and then new bone being reformed. In osteoporosis, the new bone that's being made, it cannot keep up with that old bone being broken down. So what happens is it results in this porous, weak, and brittle bones. Are you at higher risk if you have Parkinson's disease? There's a couple reasons why. There's some different theories of being directly, and then there's some indirect ones. Maybe the vitamin D is low, some other things. But the studies have shown that people with Parkinson's are at higher risk, but there are other risk factors too. So being a woman, especially if you are white or you're Asian, if you're a woman going through menopause or postmenopausal, thyroid disease, inactivity, excessive alcohol use, and then smokers. Why do you care? So unfortunately, people with Parkinson's are at higher risk for fractures than people who don't have Parkinson's disease. And if someone has osteoporosis, they can get a fracture very easily. You could walk up here, bump this, and if you have severe osteoporosis, you could get a fracture just from bumping it. There's even reports of people just having a really bad coughing spell and getting a fracture. So you want to make sure you're being monitored. How is that done? So you can get a bone density scan. This is something your primary care provider can order. And people who are at high risk, the experts say that everyone that is at risk for osteoporosis, more than just your normal aging, that you should get one over the age of 50 and then follow the normal recommendations for bone density scans. And this is really important. I will be honest, the way our office visits go, we don't have time to ask everybody everything. The visits can go this way or that way. But of the people who I have asked if their primary care providers have ordered bone density scans, I think I've had one man tell me that they've ordered them. All the other men have said no. Most of them have been women who are older, and again, no men. So men with Parkinson's disease are at risk for it too. So everybody should get screened for this. What can you do to prevent it? Well, Dr. LeVay just gave you a great talk on the importance of exercise and a healthy diet. Vitamin D and calcium are also really important. Avoiding tobacco, excessive alcohol, and taking care of the other health conditions that put someone at risk. Is it treatable? Yes. In fact, one of the medications that is sometimes used to treat osteoporosis is being studied in Parkinson's disease right now. Next slide, please. So this is the TOPAZ study. I can't see my slide to tell you exactly the steps, so I'm just going to talk in general. But basically what this is it is an online study to start with, where you go to the website, you can say you want to be in the study, you'll do a health survey, a consent form, they'll do a video visit. If they find that you qualify for the study and you want to do this, then they enroll you. So the purpose of this study is to use this FDA-approved drug for osteoporosis, give you a one-time infusion, and see if it reduces the risk of fractures. So, because again, there is a higher risk. So it's seeing if it can reduce the risk. So what they do if you qualify for this study is they mail you a 2-week supply of vitamin D that you take. Then there's a whole set of nurses out in Colorado, and they fly to your home. So well, obviously they're not going to land at your home, but they fly to your city, they drive to your home, and they come in and they give you a 45-minute IV infusion of this medication. It's supposed to last 2 years. And after you've completed that part of the visit, they do compensate you for $100. And then after that, again, it is a one-time infusion. After that, though, they do check in with you. And I'm not sure how many years they check in with you, but they check in with you every 4 months. And then per year that they check in with you, they give you another $50 to compensate you for your time. So that is something that involves the osteoporosis and Parkinson's disease. Next slide, please. So the last few topics I'm going to talk about are vitamin D and B12, the last one which ties in the vitamin D and the osteoporosis. So vitamin D is necessary for all of us. It has roles in the bone health that we were just talking about. It helps with immune function. It helps with inflammation, glucose metabolism. The list goes on and on why we need vitamin D. Studies have found vitamin D to be low in people with Parkinson's, and this can be found with a simple blood test. So people, think like, how do I know if I have low vitamin D? It's just a simple blood test. Your primary care provider can order it. Sometimes we order it too. If somebody is complaining of a lot of fatigue, somebody's complaining of some cognitive changes, or we notice it, then this is often one of the things that we order on a panel. What happens if you have low vitamin D? If it's really severe, again, it puts you at risk for the osteoporosis, might have some bone pain, might have some brittle bones. There can be muscle weakness. You can have some cramping. It can worsen people's mood. As I mentioned, cognitive changes, thinking, fatigue. So those are some of the symptoms you can experience. And then if it's low, a supplement can be taken. Now, you shouldn't run out and just take vitamin D. Vitamin D is not excreted in the same way that a lot of the vitamins, if you take too much, then you excrete them out, the excess. That's not the case with vitamin D, and it can really build up, especially if somebody's taking high levels. So typically, even if I order a vitamin D level, if it's low, I'll send you to your primary care provider so that they can get the right amount for you, and then they can do the proper monitoring afterwards. Next slide, please. So the last thing I'm going to talk about is vitamin B12. This can cause some of the same symptoms, the fatigue, depression, irritability. It can cause neurological changes, so numbness and tingling, problems with walking and balance. If you're somebody with Parkinson's who has problems with walking and balance, the last thing you need is to add insult to injury and then have a low B12 level that's causing you to have walking and balance problems. So this is another thing that has been found in people with Parkinson's disease in several studies to be low. It's even been found to be low prior to people's diagnosis. Levodopa can, in some circumstances, put people at higher risk for lower B12, and probably just about everybody in here who has Parkinson's is on some form of levodopa. But in some of the studies, people with Parkinson's are found to have the low B12 before they even start medication. So it's not just medication related. And not that this is related to Parkinson's disease, but I have a lot of patients on metformin or patients who are on medications to help with acid reflux. Metformin blocks the absorption of B12. So a lot of times people that are on metformin are at higher risk for low B12 too. So I often check it in people that I know are on that, and especially if they're on the levodopa as well. So same thing in regards to the vitamin D, simple blood test. We often do it if somebody's having fatigue, cognitive changes. I try to do it in people at least once a year, or I'll look back and see what their primary care provider has ordered and if they have it. One thing with B12 is that even though a normal range, and this is going to depend on the lab, but even though a normal range might be like 211 to 911, 200 to 900, in the neurology world, we like to keep it above at least 400. and often 500, because in about 5% of the population, it's been found that people can have neurological symptoms, even if it's normal, but in the low normal range. Sometimes people might be getting enough B12 in their diet. They might be taking a pill, a supplement for it. The under-the-tongue ones typically are absorbed best. But sometimes it's still not enough, and people might require the injections. So that is, again, something that can be followed. Next slide. By your primary care provider. So the tests that I talked about for bone health, for the vitamin D, for the vitamin B12, these can all be ordered and monitored by your primary care provider. And I do see some patients who don't have primary care providers. They're invaluable. Everybody should have a primary care provider. You should see them on a regular basis, not just when there's a crisis. If you have a sudden change in your Parkinson's, the first thing we're going to do is send you to your primary care provider to make sure you don't have a urinary tract infection, make sure something else is going on. So if you don't have a primary care provider, or you haven't seen your primary care provider lately, please schedule an appointment. Next slide. So what are your next steps? Your next steps are thinking about, who do you have on your team? Friends, family, exercise coaches, physical therapists. Who's on your team? Who needs to be on your team so that you can be as healthy as you can be as you fight this disease? Next slide. So for more information, there is a plethora of information out there. The Parkinson's Foundation is fantastic. If you go on their website, you put in constipation. Every webinar, every podcast, every handout they have on constipation is going to come up for you. That's how you learn about some of these topics that you might not be able to have time to talk about in the office, whether it be your primary care provider or your movement disorder specialist. Locally, we have the OPFNE, there's the Davis Finney Foundation, Michael J. Fox Foundation. It doesn't matter to me where you get your information. Just make sure you're educated so that you can stay as healthy as possible. Next slide. So one final note, and it goes back to what I said at the very beginning. Just because I talked about it doesn't mean you're going to experience it. And just because you have Parkinson's disease doesn't mean that everything is Parkinson's disease. Thank you for coming today. You are going to be moving very soon, and so I hope you enjoy the rest of your day. Thank you.